Alrighty, good morning. We are going to be talking about oxygenation today, and I thought that we're wrapping up the semester. If you think about it, we are past the midterm, so why not have a nice, relaxing meditation session to start the day? So I'm going to play this video. We're going to learn about deep breathing. It'll last about 5 minutes, and then we'll actually get into the lecture. Sound good?
Yeah.
Alrighty. And play.
Helpful to sit with it. So let's practice a deep breathing, focused meditation now. To start, most patients find it helpful to sit with the feet firmly on the ground, your knees bent at a 90-degree angle, your hips bent at a 90-degree angle, your back straight. But if you do have back problems, to sit comfortably with a cushion or pillow. Now, most people, when focusing on the breath, find it comfortable to close the eyes. But if you do so, try to keep your eyes still engaged, as if there's a mountain range off in the distance. It just so happens that your eyelids are closed. This is to keep us awake and involved in the meditation practice. Now, you can close your eyes now. I'll guide you through the meditation. To start, take a deep breath in through the nose. Feel the breath in your body, your lungs expanding, and even your belly expanding, and breathe out through your mouth. Take another deep breath in through the nose. Feel the breath in your body, and breathe out through the mouth. We're now going to focus on a cool sensation of the air as we breathe in through the nose. Breathe comfortably at a normal pace. And as you breathe out, focus on the warm sensation of the air as it exits your nose. Continue to breathe comfortably in and out of your nose. And pay attention to that repeated process of noticing the cool air as it enters your nose and the warm air as it exits your nose. Continue this for a few more breaths with our focus on the cool air in and warm air out. You might have noticed by now that your mind has wandered. That's perfectly normal. Everyone's mind wanders. Bring your attention back to the breath, to that cool air in and the warm air out. And now I invite you to bring your attention back to the room, to your feet on the ground, the chair beneath you, to any sounds or smells that you might be experiencing. And when you're comfortable, if your eyes are closed, to gently open your eyes. This meditation practice is a small, short example of how to bring out the relaxation response. At the Benson Henry Institute, we encourage patients to build a meditation practice into your daily life for, at first.
All right. We all still awake?
Yes.
All right. Ready to start the lecture? Alrighty, so chapter 33, oxygenation. Following this presentation, you will all be able to identify the primary anatomical structures associated with the respiratory system. You'll be able to define and differentiate ventilation, respiration, and oxygenation. You'll be able to describe how the aging process affects the respiratory cycle and the lung functioning. And you'll be able to develop treatment goals pertaining to the respiratory system. All right, the respiratory system. Respiratory system is divided into the upper airway, the middle airway, and the lower airway. The upper airway is everything above the larynx, which is this red section here. The middle airway is the trachea, the bronchi, and the bronchioles, and the lower airway contains the lungs as well as the diaphragm. The diaphragm is the muscle down here, and it is the muscle associated with 70 to 80% of the respiratory functioning. And the primary functional units of the lungs are the alveoli, which we'll discuss in the next slide. Any questions on structure and functioning before we move on to slide number 2? Negative? Okay, great. All right, so the alveoli and the pulmonary system. The alveoli are the main functional units of the lungs, and active respiration and oxygenation are dependent on the functioning of the alveoli. These are tiny air sacs which resemble hollow graves, and they have surfactant on the inside to keep them open. They are also surrounded by capillaries which facilitate oxygen diffusion, and the alveoli capillaries, losing my notes. They move CO2 out of the bloodstream and oxygen into the bloodstream. All right. So the rate of diffusion across these capillaries can be impaired due to a number of factors, such as edema, pleural effusion, pneumothorax, or asthma. And we're moving on to definitions. So ventilation is the movement of air in and out of the lungs through the act of breathing. The muscles associated with the ventilation include the diaphragm and intercostal muscles. Respiration is the exchange of gases and oxygen within the lungs. And finally, oxygenation is how well the cells, tissues, and organs are supplied with oxygen. An important thing to note is that the pulmonary, cardiovascular, neurologic, and musculoskeletal systems must all work together to achieve adequate oxygenation. Can anyone take a guess at why? Anyone? Alright. How do multiple organ systems work together for the purpose of oxygenation? Good, circulation, that's the cardiovascular system. We also have the neurologic system, which stimulates the act of breathing. The musculoskeletal system is the diaphragm and the intercostals. Anything else we can think of? We have a quiet group today. Alright, well, moving on. Factors affecting ventilation. Alright, so the main factors which impact ventilation are the rate of breathing, lung elasticity, lung compliance, and airway resistance. Now, based on the last slide, can anyone please define ventilation for me? Good. Ventilation is the movement of air in and out of lungs. All right. So for respiratory rate and depth, then the respiratory rate is how fast you're breathing, and depth is how much air you're actually pulling into the lungs. Referring back to our discussion about the diaphragm contracts and goes down when inhaling, then rebounds back up when exhaling. Another thing to consider is both hyperventilation and hypoventilation. Hyperventilation is related to breathing too fast. It can be caused by medications, neuro abnormalities. It can be caused by high altitudes where you need a faster faster respiratory rate to take in adequate air. It can also be related to heat, exercise, or even anxiety. On the flip side, hypoventilation occurs when there's a decreased respiratory rate or shallow breathing, which only moves small amounts of air in and out of the lungs. This can lead to hypoxemia. Hypoxemia will be discussed in a later slide. Does anyone want to try to take a crack at defining that? Come on. Hope. What is hypoxemia? Good. All right. So moving on to lung elasticity. Lung elasticity is also referred to as elastic recoil, and this is the tendency of the lungs to refer back to their original positioning after being stretched. Poor elasticity can allow air to become trapped in the alveoli. Lung compliance is the ease of lung inflation. This can be impaired by edema, loss of surfactant, or scar tissues. Finally, airway resistance is resistance to airflow within the airways. Impairment is usually due to bronchospasm or inflammation, which reduces internal diameter of the lungs. All right, the developmental stages and the respiratory cycle. So first, we'll start with infants. Infants have narrow airways and everything is smaller. The structures are still developing, and this puts them at an increased risk of infection, as well as choking. Neurologically, infants can also have abnormal ventilation with periods of either tachypnea or apnea. Finally, their alveoli are still developing, and infants have decreased surfactant. Why is the decreased surfactant an issue? Mm-hmm. Reducing tension, and also surfactant helps keep the alveoli open.
When do you think that a fetus has enough surfactant to be born? Think about this if you've ever dealt with someone or know someone that had a preterm baby.
Are they 29 weeks, right? 30, 34 weeks? No, 34 weeks.
That's prime time.
I would say 37 weeks.
About mid-20s is a survivable baby, okay? But what do you think the main goal is with a baby that's 25 weeks old?
To get their lungs working properly.
We've got to get that lungs. We have to get that surfactant. That's one of the reasons, one of the first things we give a preterm baby is medications to kind of boost their surfactant production, okay? So surfactant is very, very important. I promise that's my only interruption.
Thank you. All right, so moving on from infants with commentary by Professor Bowers onto toddlerhood. Now, toddlers occur once after the infant has reached their first year of life. The main issues associated with toddlers are environmental exposures, such as allergens, germs, pathogens, and tobacco smoke. Like babies, toddlers are putting everything into their mouth. If it's in the environment, it's going to end up in their lungs. Toddlers also have disproportionately large tonsils and adenoids, which can be a risk for choking. Once a toddler reaches 3 years old, they go on to the preschool age. Preschool and school-age kids experience increased cardiorespiratory development. Like toddlers, they have a high risk of exposure to environmental pathogens, and upper respiratory infections are common, such as asthma. Anatomically, adolescents are much like tiny adults. Typically, an adolescent is at the prime health. The cardiorespiratory structures reach full maturity and size during adolescence, and they tend to have a more robust immune system, which puts them at a decreased risk of infection. However, adolescents are also at a risk of trying out smoking and other recreational drugs, which can impair their lungs. Now, on this PowerPoint, I did put pregnancy in with young and middle adulthood. However, adolescents can also become pregnant. During pregnancy, maternal metabolism increases by 15%, which increases the O2 demand. The uterus pushes up against the diaphragm, which impairs inhalation, and the circulating blood volume will double by the second trimester. Maternal respiratory rate will increase due to When you have a baby, everything gets squished up and breathing becomes harder. All right, moving on to young and middle adulthood. Unfortunately, during young and middle adulthood, then you move from the prime health to decreasing. You'll notice that a lot of respiratory conditions most significantly impact the very young and the very old. Young and middle adults have much of the same risk factors as adolescents, however, their cell regeneration will decrease during this age stage. Moving on, older adults are at risk for reduced lung inflation and have a higher infection risk due to a declining immune system. They can also have age-related calcification of the intercostal cartilage, which leads to lesser recoil. Their alveoli lose elasticity. They also have a less effective cough reflex and a decreased ability to expel mucus and irritants. Finally, in older adults, conditions such as GERD irritate lung tissues, which can lead to scarring, inflammation, and aspiration. Any questions so far? No? Okay. All right, the 4 H's of oxygenation. It is very important that you understand these vocab words. They will end up on the test. A lot of them look the same and sound the same, but it's important to note the key differences. So hypoxemia is low arterial blood oxygen content. Hypoxia is inadequate oxygenation of the organs and the tissues. Hypercarbia is also called hypercapnia, and this is an excess in dissolved CO2 in the blood. And hypocarbia, also called hypocapnia, is low levels of dissolved CO2 in the blood. Anyone want to try to take a crack at how one of these things happens? Give me a diagnosis or a situation for hypoxemia.
COPD.
Good, COPD. Diagnosis for hypoxia? You can just shout it out. Yep, disturbed breathing pattern. What can cause someone to retain CO2? Poor circulation. We can think about sleep apnea. And then finally, what can cause a decrease in CO2? How about anxiety? How about tachypnea? How about breathing too quickly? Good. All right, so I like this slide for a couple of reasons. First off, it shows a picture of what we're going to be talking about. Second off, it organizes the different oxygen delivery devices by the level of flow. It acknowledges whether this device is for mouth breathers or for nose breathers. And also it notes whether it's a comfortable device to wear or not. Look at all of these. Do you think they're all comfortable? No? All right, and I do have some examples on the desk over here that I'll grab really quick. All right, so on the low flow end, we have a nasal cannula, we have a face mask, and then we have a face tent. Let me find my face tent that I'll let y'all pass around. Oh, thank you. All right, so low flow oxygen devices are typically non-invasive. The nasal cannula is the basic oxygen delivery device, and it can accommodate between 1 to 6 liters of oxygen per minute. The nasal cannula, as we know, is applied at the nares under the nose and loops around the ears. The next step up from that is a face mask. This can accommodate between 5 to 10 liters per minute, and they fit tightly. Now, face masks do have a higher level of oxygen delivery. However, for someone who's claustrophobic, it's not a good choice. In comparison, the face tent that I've passed around is a better option for someone who's claustrophobic because it wraps around the jaw and the nose is left open. However, in my own personal practice, I've noticed that with the face tent, there is a high risk of moisture-related skin breakdown because these oxygen devices are typically humidified. All right, moving on to the high flow end, we have the oxidizer, the Venturi mask, the non-rebreather, the heated high flow, and the BiPAPs. Do we have these here? All right, so these high flow devices are typically more invasive, and they're reserved for when a patient isn't compensating well on a lower level of oxygen. So a key factoid about non-rebreathers, just like you hear at the airport, oxygen can be flowing without the bag inflating. That joke didn't land. Oh well. All right. So the bag does not need to be inflated, but it can accommodate between 6 to 15 liters of oxygen. Now, heated high flows, which is this blue one. Where's my mouse? There's my mouse. Yeah, these were a big hit during COVID. And want to take a guess at why? All right, so heated high flows, then they go on much like a nasal cannula. However, they can deposit between 60 and 70 liters of oxygen per minute. Heated high flows and BiPAPs, then they're your last ditch effort before we put someone on a ventilator.
You keep saying heated high flow. Is there heat applied to it?
Yes, so there is typically a bubbler device that is typically water or saline, and the water is heated to about body temperature, about 35 to 37 degrees Celsius. Can we think about why having warmed, humidified liquid might be helpful for perfusion?
To keep it from drying out.
Yep, to keep the airway passages from drying out. And also it does help with helping the lungs recognize it, because the oxygen will bind to the water and it'll diffuse more easily. All right, so if you've ever stuck your head out of a moving car, then that's pretty much what a CPAP and a BiPAP feels like. All right, a CPAP stands for continuous positive airway pressure, and a BiPAP stands for bilevel positive airway pressure. Both these devices require an airtight mask to push the air into the lungs. With BiPAP specifically, can anyone name some safety considerations we might want to consider? Yep, safety considerations for a BiPAP. Good, skin breakdown. Also consider aspiration. If someone were to vomit on a BiPAP, you better yank that thing off immediately. Do not pass go, because just like it's pushing air into the lungs, it's going to push that vomit right back into the lungs and cause aspiration pneumonia. I've seen it happen, it's not fun. Also consider claustrophobia. And we think that people that are on a BiPAP with low oxygen levels, they might be a little bit confused. I'm seeing some bobbles, okay? Yeah, so make sure that the patient is not self-removing their BiPAP. There should be a beeper on the machine to tell you so. However, the beepers are quiet, and if they're all the way down at the end of the hallway, you might not know. So you need to round on these patients more frequently to make sure that they're breathing. All right, so one oxygen delivery method that is not on the slide here is trachs. I'm sorry, Johnny, you just sat down.
No, that's all right.
I have trachs. All right, can anyone tell me what a tracheostomy is? Yes, it is an invasive artificial airway that is cut into a person's tracheal cavity. This is done when the nose and the mouth aren't working appropriately for breathing. All right, so a person who has a trach, then they can breathe on room air. However, when they're in the hospital, we typically put them on supplemental oxygen. A trach collar looks very similar to the simple face mask that I passed around. However, it's much smaller and it goes over this neck opening as opposed to on the face. All right. And then the thing with a trach is it is a sterile procedure and you want to make sure that it's patent because there's a lot of mucus in this area. Have you guys learned about trach suctioning?
They sure did.
All right.
I taught them.
All right, questions about types of oxygen delivery devices before I move on? Did everyone get to play with the toys? Alrighty, breathing patterns. So I think an effective way to understand this is we're gonna all breathe it out together. We're gonna follow the zigzags. It sounds corny, but it helps, I promise. All right, so eupnea is normal breathing. So we're all gonna follow the wave. We're gonna breathe in and out, and in and out. All right, so that is the normal one. What is a normal rate of breathing? 12 to 20, good. All right, what if we take it a little bit faster? Breathe in and out, and in and out, and in and out, and in and out. Yeah, tachypnea. This is a respiratory rate over 24 per minute. Fast, shallow breathing, generally caused by hypoxia or increased O2 demand. All right. Now, what can cause tachypnea? Another thing that we talk about is anxiety. On the flip side, we have bradypnea, which is decreased breathing. All right, these are low, slow respirations, in and out, in and out. This is less than 10 per minute and can be caused by sedation or neuromuscular conditions. Now, tachypnea, bradypnea, and eupnea, hopefully in your career, this is all you see. However, it's important to know the weird ones so you can identify them. All right, so Kussmaul respirations. Kussmaul respirations are caused by renal failure and diabetic ketoacidosis, and this is an increased respiratory rate with abnormally deep respirations. So looking at tachypnea, then it is fast and shallow, where Kussmaul is fast and deep. Anyone try it out? Might get lightheaded, but shaking our heads no? Okay. All right, Kussmaul can be a compensatory mechanism for metabolic acidosis, and it can also occur as a fear and anxiety response. All right, Biops respirations. This is an irregular respiratory rate of varying depth. This one looks strange, doesn't it? Yeah, there's a big period apnea in the middle here. All right, so respirations are usually shallow and have periods of apnea, and they're often associated with damage to medulla and increase in cranial pressure. If you see someone doing this, think there's something wrong with their brain. All right, now Cheyne-Stokes is also associated with brain abnormalities. This is a gradual increase in depth of respiration, followed by a gradual decrease in depth, then a period of apnea. It's like, it's weird. I've seen it a couple of times. All right. Finally, apnea. Y'all, what's apnea? Nothing. Is that a medical emergency?
Yes.
Why?
Because I'm breathing.
Mm-hmm. Alrighty, abnormal respiratory signs. This is where your assessment skills come into use. Abnormal respirations can indicate a medical emergency. From day one, we are taught airway, breathing, and circulation. Can anyone tell me what body positioning someone in respiratory distress may have?
Sorry, repeat yourself.
What body positioning do you think someone in respiratory distress is going to have? Do we think they're laying flat, comfy in the bed? Yeah, tripod positioning, sitting upright, trying to get that lung expanding. They might have nasal flaring. When we talk about accessory muscle use, what are we talking about? Yep, using their shoulders, using their intercostals, pretty much using their whole body to pull air in. All right. Now, this dusky coloration, where do we note this? Where would we see dusky coloration? Over the whole body? Hopefully not. Yeah, in the face, in the lung, or in the gums, in the nail beds, sometimes in the nares. This is what you're assessing when you're doing cap refill. Are they picking back up? All right, so think gray and blue is bad. Pink is good. We like pink. All right, what are some abnormal vital signs you might find with respiratory distress?
Oxygen stats is low.
Yep, their O2 stats are going to be low. Something that we might also want to think about is, are they having pain? Not being able to breathe is painful. Now, pain has both a correlated and causative effect on breathing. This could be indicative of severe complications. When someone's in pain, they typically have shallow breathing. This increases the risk of atelectasis. Anyone know what atelectasis is? Good, a collapsed lung. All right, and circling way back, then what is a lipoprotein that we can use to prevent collapsed lungs? Surfactant. Good. All right, what are some abnormal lung sounds? Yep. Wheezing, rhonchi, crackles, stridor. Pretty much anything that's not clear with the air moving evenly. Could there be diminished lung sounds?
Yes.
How do you think that sounds? Diminish.
They're not reaching out to the
Right, you have to kind of know what normal is, but if you listen and those breath sounds sound very far away, you know, that diminish. So, a lot of people put diminish, and it might be a shallow breath, but that doesn't necessarily mean diminish. So I always use the rule, if those breath sounds sound like they're in the patient next door, that's diminish. I lied, I've interrupted again.
Alrighty, cough characteristics. You gotta know, are they coughing? Is it wet? Is it dry? Are they hacking? Do they sound like they're bringing up the whole lung with them? Oops. Alright, and then with lung output, then consider sputum characteristics. What color is normal sputum? Clear, good. What if it's green? What if it's red? What if it's like a pink, frothy pus? Mhm. Yep. Little tidbit for the future, pink and frothy, think heart failure. Alrighty, we have made it to the last slide of the PowerPoint. Alright, so respiratory system treatment goals. We want to promote optimal respirations, encourage smoking cessation, encourage people to get their vaccines, especially the very young and the very old. We want to prevent pneumonia and communicable disease, advocate washing our hands, do medication counseling, and hydration. Why do we want to do all this stuff? What, is it going to help?
What? Is it going to help?
Yeah.
Yes.
Mm-hmm. How would you promote optimal respirations in your patient? What would you tell them? Good. Teach them proper breathing technique. Why is hydration related to the respiratory system? Hydration, then first off, it moistens the respiratory system, and also it can break up mucus. All right, how do we prevent pneumonia in our older patients? All right. Any questions about anything that we've gone over so far? No? All right. Well, just like last time, we are going to go over a think, pair, share activity. So we're going to break up in small groups. All right, does anyone want to read this aloud for me?
You are a nurse working at an urgent care clinic. Your patient is a 35-year-old female here for a respiratory care appointment. She reports increased work of breathing, trouble breathing when laying flat, and allergy symptoms including itchy eyes and a runny nose. Your patient is also a mother of an 8-year-old, a 3-year-old, and she is currently 30 weeks pregnant. During your visit, she expresses concerns regarding respiratory health during cold and flu season for both her and her children. Based on the information learned during today's lecture, 1. What information would you give her? 2. State one nursing diagnosis, care goal, and treatment intervention you could implement during this meeting.
All right, talk amongst yourselves, and when you're ready, tell me what you think.
It's kind of 50-50. So I would just
Alrighty. People in the back, what are we thinking? I'm sorry, can you repeat? Ineffective airway and breathing. All right, is that for the patient, or is that for the kids, or is that for everyone? Everyone, alrighty. People in, yes, vaccinate. All right, my friends in the front.
We're gonna encourage a lot of fluids, and I don't know if it was kind of hard of hearing. We're gonna also encourage that they incline a little bit, especially if they're laying down, at least 30 to 45 degrees, if they feel it.
Mm-hmm.
Vaccinations for great.
Mm-hmm. Are we gonna talk about hand hygiene?
Yeah.
Mm-hmm. Mm-hmm.
I'm gonna interrupt again.
We know you interrupted.
Alright, so, alright, I like everything y'all said. Let's look at these kids, 8-year-old and a 3-year-old, right? Okay, so y'all mentioned hand hygiene, alright? Let's always start with the simplest stuff, okay? So hand hygiene, wash your hands, right? Okay, has anybody ever heard of cough etiquette? You know what cough etiquette is? That's right, when you cough, you're gonna cough into your elbow, cough into your shirt, something's got to cover that cough, okay? So that's something to teach your kids. I hate to tell you, sometimes you have to teach that to adults too. But stuff like cough etiquette, anything else that we need to, bring it to the child level? Okay, so we can talk about nutrition, so vitamin C, fruits, veggies. Let's cut back to the junk food right this second, okay? Do we want to tell them to run out to Walgreens and buy vitamin C packs and emergency and elderberries and all that stuff? We don't want to. All right? Vaccinations. Who up there can be vaccinated? You got a 3-year-old, an 8-year-old, and a 35-year-old who is 30 weeks pregnant. Every one of them can get vaccinated. Good. Okay.
All right, my friends in this front corner, I think that your last group, or did I not hear from these guys?
I kind of spoke for my group.
You spoke for your group? Okay. All right, front and center. All right, one more comment, then we can take a pee break.
I'm trying to think what didn't get said. Vaccine.
Maybe like an allergy medicine?
Mm-hmm. Yes. Is this person having a bacterial infection, or are they having seasonal allergies, or did their kid bring something from viral?
Teaching their kids not to share stuff.
Mm-hmm.
Or, that sounds really bad, but.
That's fair. Yeah?
Okay, so people have said allergies and stuff like that, but they were talking about with an allergy. So what about she need to like take the prenatal vitamins, make sure the pregnancy good,
Mhm.
things of that nature, right?
Mm-hmm.
So that's the one right there.
Good, yep. All right, well, thank you all for letting me talk with you today.